Friends, we'll be starting this very important course on IOL fixation techniques, which we have been doing regularly. And I'm Dr. Mohan Rajan. I'm the chief instructor for this course. And this IOL fixation techniques managing decentered, dislocated, dangling IOLs, which is becoming a very common problem today. And we need to know exactly how to manage them. And this course we have been doing for the past almost 8 to 10 years, very successfully in American Academy, in the ACRS, ESCRS, Asia Pacific Academy of Ophthalmology meetings, and WOC and everywhere as well, and with a very huge participation. We have a stellar faculty here. Dr. Sujata Mohan will be talking about sutured scleral fixation, management of subluxated IOLs. Amar Agarwal, who is the master of glued IOL, is going to talk on that as well. Nivian is going to talk about a new innovation on the CMT flex lens. So, I'm going to talk about after PCR, what next. These are my financial interests. How many of you in the audience have not had PCR at all? Anybody can I have a show of hands? Okay, right, very good. So if you are an eye surgeon, ophthalmic surgeon, you will have PCR some part of time. So one guy put up his hand in Amritsar, Sardaji, and we found out that he is an ENT surgeon. So unless you are an ENT surgeon, because he came there because his wife was an ophthalmologist. So early recognition combined with the advanced instrumentation enabled effective management. Anticipate PCR in patients who have got traumatic cataract, post-vitrectomy, posterior polar cataracts, and brown cataract, pseudo-exfoliation. All these patients, you need to make sure that you have a PCR, they can anticipate PCR. So when you have a PCR, you are in a very agitated state of mind. You do not know what exactly to do. You can have an IOL in the bag, IOL in the sulcus, and the main objective of the course is how to manage a PCR and how to put a lens depending on the support, the AC IOL or Aris claw, SF IOL or Yamane or the glued IOL or CMT flex lens. So this is, I think, a very important slide which for all of us you should understand. When you have PCR, when you have coaxial irrigation aspiration, coaxial means the irrigation and aspiration are on the same port. If you have coaxial irrigation aspiration, what will happen is the PCR will enlarge right under your eyes, and more vitreous is like a tsunami, more vitreous will start coming into the anterior chamber, and the PCR will start enlarging. That will produce traction on the vitreous base, traction on the macula, producing cystoid macular edema as well. But if you have bimanual means the irrigation is separate from the aspiration, then that will tamponade the PCR and also prevent hydration of vitreous, and whatever hydration is there, whatever vitreous is there, you can remove. Now this is one of my phaco fellows. You can see the date as well. And this is something which is very common to all of us. When you have PCR, suddenly don't withdraw. So don't pull out of the eye suddenly. This is what happens. When you become jittery and pull out of the eye, see if you pull out, what will happen? See what is happening, the whole PCR starts enlarging. The nucleus also starts going into the vitreous cavity. And then immediately I go in and do an anterior vitrectomy. At that time the tricot was not available to us. But always remove the vitreous first and then remove the cortex. Don't remove the cortex in the presence of vitreous in the anterior chamber. You can produce traction in the vitreous base. And what happens to the nucleus? Depending on the karma you have done, the nucleus will come up. So I have done a lot of karma, and that's the reason why the nucleus came up. You can see here I've got the nucleus up, and then immediately I put the phaco probe, and then subsequently this patient, I did an anterior vitrectomy and removed the cortex as well. And you can use the same, the cut IA, the IA cut on your phaco probe. Only thing is you need to separate the irrigation from the cutter, very important, and then put a multi-piece lens into the sulcus in the patient. You can see this is another patient, and this is a former union minister who came to me, and these politicians commit a lot of sins and they come to you. You can see here what happens is the last piece, okay, the last piece there's an occlusion, post-occlusion surge, and there is a PCR, small PCR there, and I go ahead and remove the nucleus, and then immediately I don't withdraw from the eye, I inject viscoat. Okay, the viscoat is something which is very, very important. The Alcon's probably best innovation is viscoat. We'll go and plug the PC tear. You'll go and plug the PC tear and stay there forever, and then slowly withdraw the phaco probe, and then go bimanual and remove the cortex and the vitreous which is there. And this is a postoperative picture of this patient. Because we don't have much time, this is a sulcus fixation. Again, you can see here, this is a patient who is a gynecologist who came from Kerala, and she wanted a toric lens. The nucleus started descending into the vitreous cavity after the hydrodissection, and immediately I brought it out and then did an anti-vitrectomy and put a lens in the sulcus as well. So this is something which is not uncommon, because you can see what is happening here. I'm doing a hydrodissection and I'm not decompressing the nucleus. Every time you do a hydrodissection, you need to decompress and see what has happened. When you do keep on doing a hydrodissection without decompressing the nucleus, there is an anterior capsular tear, and this anterior capsular tear, actually the anterior capsular tears are the most dangerous in my opinion. They can wrap around the equator and go into the posterior capsule as well. So I think it's very important for you to understand this ball game. So as soon as I put the phaco thing into this, the nucleus started descending into the vitreous cavity. This is a posterior polar cataract. I'm sure everybody has undergone this posterior polar cataract. You can see here, I am going with a slow motion phaco and going ahead with the flip and chip and flip technique. I'm bringing that with the lower parameters. But what you see underneath the epinucleus, when you remove the epinucleus, it's a large PC dehiscence. It's actually not a PC tear. It's a PC dehiscence which occurs in posterior polar cataract. I will go ahead and then immediately I put in viscoat and come out of the eye. If you don't have viscoat, doesn't matter, whatever viscoelastic you have, you can just put it inside. And they immediately create a right side port, immediately put tricot there, diluted tricot 1:3 and do an anterior vitrectomy before you remove the cortex or the epinucleus. And then again, whenever you come out of the eye, you need to put viscoat or whatever viscoelastic, as I told you, and try to remove the nucleus and epinucleus and the cortex as well. I'm sorry, the cortex and the epinucleus. And then you can see that the two typical pillars on the posterior capsule which is there. Never put a single piece lens which is such a large defect. Always put a multi-piece lens into the 3-piece lens into the sulcus, and then don't leave it in the sulcus. You need to capture it in the bag as well. So again, very important for you to understand this. And I leave it. I do the drop down technique wherein I drop down the trailing haptic into the sulcus, and which makes life very easy. Again, you can see another patient with the posterior polar cataract, and this also is a very important thing. And this I can see. Don't leave these lenses in the sulcus, because you need to make sure that the capsular axis is not very large. If the capsular is very large, you cannot capture it. Make sure the capsular axis is everything, and you need to capture this lens. The haptic is in the sulcus. The optic goes into the capsular axis margin. So this lens is as good as the lens is in the bag. So this is very, very important. The end point is the ovalization of the anterior capsular axis margin, which is there. You can see here, the lens gets locked beautifully without any problem, and this lens will not move a micron, and there's no problem at the UGH syndrome or anything like that. 2 months, 9 months. Again, if it's a small posterior capsular axis, small PC tear converted into a posterior capsular axis, and you can see here the posterior capsular axis definitely has got a more strength than the PC tear, and in this case I put an in-focus lens without any problem as well. So you can see the femto thing, and PPC always look at the fellow eye. The fellow eye is very important. This is again a patient with a mature cataract, and I'm seeing a fellow eye, and you can see that when the fellow eye has got a lens in the sulcus on IOL. This is again very important for you to understand that there's a possibility of a posterior polar component in this posterior thing. Again, you can see here there's two typical dehiscence of the posterior capsule. Another patient you can see here very clearly. This is again a patient who had a thing, and another 1 minute I will take. And again, you can see here traumatic subluxated cataract, which I don't want to think. Another patient with a brown cataract, you can see because of the anterior capsular tear. As I told you, the anterior capsular tear, which is more important, more dangerous in the posterior capsular tear, because this can wrap around the nucleus or around the equator. And this patient, you can see a brown black cataract, and very old patient as well. So immediately I brought it up, and don't hesitate to convert. In this case, I hesitated to come this thing. I didn't have any ego, and make sure that I brought it out, and then did an anti-vitrectomy, put a lens in the sulcus, and this patient did very well post-operatively and also. So if it is a small, this thing, huge, I think we talk about it. We can do a posterior acetal levitation, and all these things I think we are going to talk about in the how to put the lens and different types of lens as well. So PC tear is something which is, I'm going to go into the last slide quickly, and small PC tear, convert into PCC, do not pull out, inject viscoat, use tricord preservative free, bimanual automated anti-vitrectomy, limbal or pars plana, you can use it. Remove the vitreous first and then remove the cortex and the epinucleus, appropriate IOL. Always suture the wounds because the incidence of endophthalmitis when you have PC tear and vitreous loss goes up by about 4 to 5 times. And these are all the options which we are going to discuss in this particular course. And take-home messages, prevention, recognition, management, optimum results. Thank you very much, AIOs, for the wonderful opportunity. Please email to me for Dr. Mohan Rajan for this color atlas of the retina and optic nerve. Over to Dr. Sujata Mohan. She is going to talk about the IOL fixation techniques when you have a wobbly IOLs or a dangling IOL, how to do it with the suture or the glue or whatever it is. Thank you.
Thank you. I'd like to thank the organizing committee for giving us this opportunity once again, and my co-instructor, Dr. Mohan Rajan. So my talk is going to be on dislocated wobbly IOLs. It's not coming. Okay. So I'm just going to show you some case scenarios of how to fix a dislocated IOL using 2 different approaches. Case 1 was a 70-year-old male with history of phaco-foldable done 15 years back by us. Even much more, I think, now, because those times we didn't have the single-piece foldable IOL in the bag. And he had 6x6 vision. There was no history of trauma, but he was complaining of oscillopsia. He was saying there is something moving in the eye, and on examination he had pseudoexfoliation, and you can see that the entire IOL and back complex is moving continuously, though he had very excellent vision. And since this was a multi-piece IOL, we decided to fix it using the same glued IOL technique. So here I'm preparing the eye, making 2 flaps 180 degrees apart. I'm using a posterior segment infusion. So once we have done this, now I'm going inside through the side port, and you can see how easily the IOL back complex is coming out. It's almost just hanging. So once it has come out, now I've placed it on top of the iris. I'm using a cystitome to try to remove the capsule wrapped around the lens. But since I couldn't do it, I used a vitrector to remove it because it's important that you remove the capsule. So majority of the PC I have removed using the vitrector. There was no vitreous loss in this case. And once I have freed the IOL, now I'm exteriorizing the first handpiece, holding on to the second handpiece. You can see that the handpiece has come, the first handpiece has come out, haptic has come out, and then now I'm exteriorizing the second haptic. So now throughout this procedure there was no vitreous. Now I'm tucking it into the Chariot's pockets, and the remnant anterior capsule, again I did a little bit of vitrectomy and made sure there was no vitreous by using triamcinolone and making sure there was no vitreous present. And the case went well. Glued the flaps, and also the peritomy, glued the peritomy. The case was completed. This is a problem. So let's see the post-op of this patient. So the post-op, the patient, you can see now he's moving his eyes. This is the first day post-op, and you can see the lens is very stable. We have almost about 10 years follow-up on this patient. I think when I started doing glued IOL, this was perhaps one of my the first 100 cases. So case 2 is a very similar case, 75-year-old male but dislocated IOL back complex. Only thing, the IOL was a single piece. So that there is some difference in how you're going to handle with this type of cases. So in this case, I decided to use Hoffman's pockets. Hoffman's pockets are created almost from the cornea towards the sclera. You make a pocket which is about 2 to 3 millimeters in width using a crescent knife. And you have to always check, once you've made the pocket, you always have to check it to see if it is adequate. Once you've tested it, you can make 2 paracentesis, use a 27 gauge needle, and go through the pocket. Now you thread the 10-0 polypropylene needle. One needle goes on top, the other needle goes from the bottom. So the 10-0 polypropylene is docked onto the 27 gauge needle. Now you can see both of the loops have come out, and you place it. You can retrieve it even later, but if you want to retrieve it now, then you need to take off the needles and retrieve it. And the same thing is done on the other side. So only thing, just make sure that when you're passing the needle, you are passing it through the pocket. So if you have not passed through the pocket, then you cannot retrieve. So here you can see very clearly, the first one is going underneath the haptic, and it's docked into the 27 gauge needle. Now it's pulled out. The other end of the 10-0 polypropylene goes on top, and now it's pulled out again. So the most important step here is to make sure that both the sutures are in the pocket, not outside. Now you can test it and make sure that your lens is well centered, and then slowly tie it. Just make sure you don't pull too much on one side. So this patient also almost had no vitreous loss, but in all these patients, it's important that we use triamcinolone and make sure there is no vitreous in the anterior chamber, and do a good wound toileting if we do disturb any vitreous. The next case was a case which I had been repositioned 3 times elsewhere, because there was some amount of capsule remnant which actually fooled the surgeon thinking that we could do it. So it was a multi-piece lens. And so the same technique as you saw in the first technique I employed, you just bring it out, use the haptic, and use a handshake technique and bring out the haptic, one haptic, do a little bit of vitrectomy to remove all the capsular components. So this is a handshake technique. You can see that the first haptic is being brought out. Again here another handshake technique, and the second haptic is brought out. And once it is done, you center the IOL, tuck the haptics into the chariot's pockets, and close the flap. You don't have to worry if you get some little bit of iris prolapse, because anyway we are going to put it inside and we're going to close the flap. You don't have to worry about. Sometimes you do get this, and the case is completed. So the last case I'm going to show you is again a multi-piece IOL, but a single piece IOL, but I'm going to do a slightly different technique. Instead of using a 10-0 polypropylene, I'm planning to use a cortex suture. So to bury the cortex, it's very important to bury the cortex suture. So I'm making a flap to bury the cortex suture. And what you need is, because the cortex suture is very thick, you need to make a slightly larger entry under the flap. So these are 2 paracenteses being created. And now I'm making a large entry into the eye and placed an AC maintainer. I'm using a microforceps to give the tip of the cortex suture, which one passes on top of the haptic, the other one passes below. This first one has gone on top, the next one will go below. So the same technique, very similar technique, only thing in this case I'm using a cortex suture. The same thing is done on the other side. So first suture goes on top, the second suture goes to the bottom, or vice versa, whatever is comfortable with you. And just center it. Before you tie it, again you center it, make sure that it is not pulled towards one side, it's not decentered, and then you can tie it. And it's important to bury the knot. You can even rotate the knot inside. In this case I didn't do it. This was one of my first cases with cortex suture. And you can see so much of capsule and Tehcniques pearls left. So definitely we need to do an anti-vitrectomy to remove all the capsule as well as the Tehcniques pearls. Again, you can see that I'm using triamcinolone to make sure there is no vitreous disturbance. And if there is any vitreous disturbance, you can handle it, you can see better. You can see there's a large Tehcniques pearl, and that has to be removed, because that can cause a lot of irritation, particularly if it goes into the vitreous, then it can cause a lot of inflammation in the eye. And once it is done, you can rotate the knot inside also. And then you can glue the flap. And the procedure is completed. So, dislocated IOLs can be managed in many ways. Techniques depend on the surgeon's expertise, but not only that, it also depends on the type of IOL. If you have a multi-piece, you can do a very nice glued IOL. And if you have a single piece, you can use one of these techniques. And also depends on whether the patient has any comorbidities, whether he has additional problems in the case, which may need a vitrectomy. Thank you.
Thank you, Dr. Sujata. A wonderful overview of the how to manage it ab intono, whether it's a single piece lens or a multi-piece lens. If it's a multi-piece or a three-piece lens, we can just strip the capsule and other things and then try to glue it, or you can do Yamane or whatever you are comfortable with. And if it's a single piece lens, you can use the sutures as she has beautifully shown in that particular video. And I think it's very important. Very rarely you need to, unless it's gone behind, that is gone dislocated into the vitreous cavity. At that time, you need to make sure that you do a thorough vitrectomy and try to remove the lens and extend the incision, remove the lens, and then put a scleral fixation lens or an iris claw. Now we have none other than any questions from the audience. One or two questions we can take quickly. You can use that mic there. And we have Dr. Nibian Madhivanan here, who's done a lot of work on this secondary IOLs, and he's very, very popular speaker as well. He is both very good in both anterior and posterior segment surgeries, and he's going to talk to us on the iris claw and also the beautiful innovation, which is the CMT flex lens. Over to Dr. Nibian.
Thank you, sir, for those kind words. So, respected teachers, senior ophthalmologists, my dear friends. So, I have two topics. First, I'm going to talk about the claw lenses and then move on to the CMT flex IOL. So, like sir, how he started off asking how many of you have had PCR and how many of you in the audience actually are doing secondary IOLs on your own. Can we have a raise of hands? So, it's nice to see a lot of hands, and the whole purpose of this course is when you go back, I think confidently, you should try one of the techniques. It's not that one technique is the best technique. As Sujata ma'am said, that each patient and each technique is different. Okay, how do we pause this? So coming on to the claw lens, so basically it's a relatively simple design. It's a a single piece IOL with additional fixation mechanisms in the end. So it was described by Wurst with the lobster claw that inspired him for bringing up this design. And basically it works on the enclavation of the iris tissue and it stays there. So as you can see here, this is iris claw lens. Two things that are very important before starting is always try to make sure that the opening is there. See, many of times we have gone inside and we keep doing it forcefully because sometimes there will be a small fusion at that point. So you do it forcefully, you may damage the iris and cause bleeding. The second important thing here is the forceps. There are two types of forceps. That's a crocodile mouth forceps. Just basically it has to be broader. So unless you have a firm grip of this IOL, it is not easy to enclave, because if you have these smaller forceps, it keeps slipping. So when you're enclaving, it pushes the IOL down. So these two instruments are very important just to check the lens before you start the procedure. So moving on to the first case scenario, this was a case on old aphakia that was actually planned for the secondary IOL. As you can see here, because it's a rigid lens, so we had to do a sclerocorneal tunnel. The second basic rule of PCR management, even though you can see round pupils here, you think there is no vitreous. So I always believe in staining with triamcinolone. So any secondary IOL case, as a golden rule, I stain and then wash away the tricot. You can see the remaining so much of vitreous strands there, which was not visible to the naked eye. So always a very key is have a good vitrectomy. For any secondary IOL, have a good vitrectomy. So you can do the vitrectomy through the side port or the pass plan approach. So once you do a good vitrectomy, make sure there is no any vitreous prolapse to the wound or the section. As you can see, one strand prolapsing, make sure there is no vitreous prolapsing. So put on viscoelastics to fill the chamber and then place the lens. The third trick is make sure your 0-180 degrees where you have the side ports, and then you place the lens. Take the lens inside. The other trick that I follow is my left hand is already there. So since it is a blind procedure and it is done under the iris, my trick here is I take my left hand to where I want to clip, and it is already there, and that is in the mid periphery of the iris. And then I push my right hand upwards. So that way I don't end up searching for the where to clip it. So it all happens in one motion, because once I don't do it in one shot, then I keep searching for it. So you can see a small enclavation there. So just do it in slower motion. See, my right hand is already there, and that is there in the mid periphery of the iris. Taking the left side inside. So right hand is pushing down now, the left hand is lifting up now. So simultaneously when it happens, you can clave it. So this is another case of SACS where they had an aphakia. As you can see, it looked clear, but then after you stain, you have a nice vitreous block that is there and almost coming through the tunnel. For all anterior segment surgeons, I think the best thing is to have infusion through one of the cannulas, and then you have the 20 or the 23 gauge cutters that go into any of the anterior vitrectomy machines. The trick here is just stay in the center. See, as phacosurgeons, our own tendency is to we keep moving the hand a lot, but in vitrectomy, we don't have to do that. As long as you stay in the center, the entire vitreous block that has to be removed will be removed. We don't have to go under the iris or much deeper. And once that is done, you just make sure that the ports are also clear, there is no vitreous leaking. As you can see here, this is the other type of forceps we use. Just that it has a firm grip. I always check because I've had bad instead of breaking it, and then some of them actually were fused. So there was no way that I could get an opening. Again, I'm placing it at where I want to clip. Again, at the mid-periphery. Why mid-periphery is because if you come too anterior, that is when you get those cat eyes type of pupil. And if you go too posteriorly, you can damage the iris root and cause bleeding. So you get nice round pupils. So end of the surgery, I just wash away the anterior chamber with just saline. You can see nice round pupils, good dilating pupils. So the trick again here is the mid-periphery. And sometimes in these rigid lenses, sometimes I don't try to push the lens down. So this was an old case where it was planned for a trap superiorly with a temporal claw lens. So here you can see, I'm using my second instrument to actually push the iris and then take the lens underneath. Because most of the times when you try to press it down, sometimes it tears the iris and causes a lot of bleeding. So you can actually just maneuver it like that. So make sure, sometimes you have a very small pupil, you can do that. Yes, there are complications. You can get irregular pupils, iris bleeding, iris tear, non-clipping and breakage of the haptics. But most of these complications, I think for any secondary IOLs are the same. This was one of the earlier studies that we had a publication in IGO for a large case series of claw lenses. This was before 2017 when we used to do a lot of claw lenses. So this is another publication with Dr. Amar Agarwal just comparing how the pseudo-phacodonosis is here. So these are some of the earlier pictures to just show even in claw lenses done properly, you get nice post-op pictures, nice round pupils, well dilating eyes, and you get a reasonably good view of the fundus like here. So now moving on from the claw lens to the new innovation, the CM-T-Flex IOL. It's also become another option for this thing. I don't have any financial interest. So basically, as you can see, it's a single piece hydrophilic lens design with specialized T-shaped haptics on either side. So as you can see, this is a case on aphakia. The advantage here is it's a foldable lens, so it can be done through a clear corneal incision. But for like any secondary IOL, 0-180 degree marking is very important. So the first thing we do is the 0-180 degree marking. So once that is done, we create a 2 by 2.5 partial thickness scleral flaps on either side. I usually use the crescent blade and then give a mild counter traction opposite side. So the crescent comes out and then I slice it like this. The slight variation in the technique, I find this easier, like going in. And then 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy on either side. So again here, after removing the vitrectomy and then removing the remnant cortex, so this is a specially designed, we have two specially designed CM-T-Flex forceps also. One that has a broad tip that you can see there. So as I said, this can be done through a clear corneal incision, through a regular cartridge. So as you inject the lens, you can see the T coming out. So you grab the T, and by now, don't pull the lens. See, most common mistake I've seen many people ask me is, it tears and bleeds because the remaining part of the lens is still inside the cartridge. So now all you do is just hold it and keep injecting the remaining of the lens. So you can leave the remaining of the lens over the iris or at the wound. See, now the lens is free from the cartridge. So now you actually pull it out. So now how much of force you give, it's just going to come out. Those T-shaped designs are just going to pop up. We call it the pop. So it just pops. And because of the design, it just sits there. So basically, it just avoids the amount of tucking or gluing or any suturing that is required. And because of the stem size, so this is the handshake technique where you can use the arms. Some of the surgeons have actually told me you have those dialing holes there. So we use the dialer. So there have been a lot of modifications by other surgeons. So in this journey of more than 7 years, I think I've learned a lot from other people doing it. And see, just exchanging it, holding it on the head-on position, as you can see here, they're really flexible. So basically, the amount of tissue damage that happens during all these manipulations are also very less. So you can actually see it coming out through the other sclerostomy. Just wait there. Don't be in a hurry when you're doing the second haptic. You can just see it just slides out rather than just pulling it out. And as I said, 0-180. So it's just going to be there, no tilt. So basically, and also we have an angulation in this optic haptic junction. So it is going to sit away from the iris, so you have good dilatations, round pupils, no pigment dispersions or any chance of glaucoma. Initially we were gluing it like this, but nowadays because of the stem thickness fits the 23 gauge thing, you can actually even cauterize the conjunctiva or even suture the conjunctiva, so whatever you are comfortable in. So here it really doesn't matter because of the thickness of the stem, it fits and there is no leakage. So these are some of the post-operative pictures. We have almost a 7-year follow-up of the UBM studies, and the studies that OCT are done through the sclera just to see on long term how the stability of the lens is there and if there are any erosion under the scleral flaps. So moving on, the question I get is like, what about anterior segment surgeons? I think all anterior segment surgeons can also do it. For any secondary IOL, again, the basic principles will remain the same. So since a lot of them are used, the next speaker has not come, so I'll be continuing for 2 more minutes.
You can take 1 more minute
Yeah.
because Amar is just on his way.
Yeah, just on the way. So either you can use a needle or you can use a MVR blade. So one of the tricks that somebody taught me is you make it perpendicular to the limbus. So what basically happens when you make the sclerostomy perpendicular to the limbus is the T sits at 90 degrees. So I'll just show you the next slide where you can see the T will slit at 90 degrees. So initially we used to make it parallel, so now we are making it perpendicular. So the T sits like this. So when you're pulling the other side, the lesser chances of it coming out. And also we have an angulation, that optic haptic has an angulation here, so that is marked by those holes. So basically it sits like a hammock. So that 10 degrees is given, as I said, it avoids any irritation of the iris and where it sits and almost in the normal position. So that is why we don't change the IOL power when we do the CMT flex, even though we have a constant. The third thing is the head-on position that I was showing you, and you can also use the dialing holes. Just last. So as I said, this was another case similar to Dr. Sujata, what she showed me. This was a rigid lens that was dislocated along with the bag. So it was planned for an IOL extraction. So again, because it is a rigid lens, so you can use an AC trocar maintainer or you can use an antechamber maintainer. So basically in any secondary IOLs, you don't want hypotony. So as long as the chamber is maintained, I think you can do the procedure. So this we are using an AC trocar maintainer here. And again, we're making the incisions perpendicular. So here again we have the entire, and this was some of the other modifications that were done. Instead of making a blunt entry, now we're using the trocar entry. So we're just holding the lens. We're not removing the lens, so make sure you just clear the lens from all the vitreous attachments. So once it is free, you see how smoothly the lens comes out because we don't want any traction in the periphery. So once that is there, even because I have the opening, I always prefer to do it on the cartridge because it is more controlled for me and it helps me grab the T when it comes out fast. Otherwise, it keeps flexing and folding when you just try to push it in with your forceps. So I always prefer the cartridge. Any IOL cartridge you can do, just making sure the T is there so that when you inject, you see the T comes out first. So just grab it there, just wait. Inject the remaining of the lens. And then pull it out. So we also have these curved forceps for the nasal side.
What injector is this? You have a special injector for this?
No, sir, just a regular
injector.
They're manufactured by Appasamy, so the regular injector itself can be done. So these are these curved forceps, they said they're used for the nasal side. So this was some of the modifications that I learned that using the trocar, so that makes the entry and exit of the instruments more smoother. So that's the end of the case. You can remove it and remove the AC maintainer or the AC trocar maintainer. So it can be done on table by the anti-segment surgeons also. So once again, I'd like to thank Mohan Rajan ma'am and Sujata ma'am for this wonderful opportunity. I think we've been doing it for more than 8 years here and in APAO. So thank you for this wonderful opportunity, sir. Thank you.
Thank you, Nivian, for the wonderful innovation, I would say. How many of you are using CMT flex lens in the audience? Quite a good number. I think it's becoming very, very popular, and it's a hydrophilic lens. And there is also something like a posterior curvature as well. So which means that it's you don't have any case of any UGH syndrome, the pigment of the iris rubbing on the lens and producing pigment dispersion.
Yes, sir. Some of the post-op pictures we saw some fine pigments there. So when we analyzed it, there were 2 reasons. One, those were like these post-trauma cases where we had done an iris.
Amar, please come. Amar, yeah, please come.
Where we had done an iris repair also. So then those cases had some pigment dispersion. And initially I was talking about the angulation, no? So even for us, we had some cases where the lens had turned. So it is actually facing upwards like this, like convex. So those cases had these problems. So basically if you keep it like this, that's why we have those holes for us to know. Or you can just keep it and see if it is sitting like a hammock. So this is the way it's supposed to be inserted. So but if it flips, then sometimes it can cause that pigment dispersion.
Yeah, Amar, get ready, and because we have the star of the show, none other than Dr. Amar Agarwal. Let's give a big round of applause for Dr. Amar. And for so many innovations, whatever we are talking today, the glued IOL, the SFT or the pinhole pupiloplasty or the PDEC or whatever it is, it's all because of this great guy. And he's been part of this course, and he's going to talk to us on some complex situation with the glued IOL as well.
Thank
Amar,
you very much,
thanks.
Mohan. Sorry, I was in another course. I apologize. So let's look at a couple of videos which I thought I'll show you. One is this case which I thought I'll show you. This is the triad. The patient has microcornea, aphakia, and sombering ring. Now the problem here is this. When you get a microcornea, even without a PCR, please understand me, 7 millimeter, 8 millimeter eye, if you put an IOL in the bag, it's like a fetus in a womb. It just crumble up. So the only way you can do it is if you do a glued IOL, and we published this in the year 2015, because the haptics are outside. The optic is 6 millimeter. So the smallest I can go is a 6 millimeter white to white cornea, microcornea. Another thing we designed is the trocar AC maintainer, in which the trocar AC maintainer is just like the same trocar, but here is going above the iris. You can use the Alcon trocar AC maintainer, which is blue in color, 25 gauge. These AC maintainers are very large. Second thing, you have to make a knife entry, then enter inside. If you put a pars plana, you can create this problem of a choroidal detachment or some other retinal complications also can come into play. So look at this. I have done the scleral flaps. Look at the blue coloration there. That's the trocar AC maintainer. Now the problem in this case is there is aphakia, there is a rupture, but there are sombering rings present. Can I leave them behind? If I leave a sombering ring behind, please understand, what will happen? It can produce an IOL tilt. It can fall down. It can produce inflammation. So there are various complications which can occur with a sombering ring. Here you can see a sombering ring on the retina. I brought it up, but it is a headache. They cannot be removed by vitrectomy probe. We published the IOL scaffold in the year 2013. So we thought the same principle we use for sombering ring. Make the flaps, but remember, the scaffold has to go behind the sombering ring where there is no capsule. So the only way that can be done is, it can be done as a glued IOL or a Yamane IOL. So either it will be a glued IOL scaffold or a Yamane IOL scaffold. Then you do a vitrectomy there, break the adhesions, remove the iris hooks back again, and phaco-emulsify this sombering rings. This is the way to manage this. And we published this in 2015 in JCRS. So you can see now I'm enlarging that opening there. Here I'm just showing you another case in which I put a sombering ring but anterior to the sombering ring, a glued IOL. Look at the mistake I'm doing. How will I reach the sombering ring? The mistake is the glued IOL has to go behind the sombering ring. So look, I'm now catching the haptic there. You can use a J&J 3-piece IOL. Once that goes inside, the optic goes in. Now look, I'm going to do the handshake technique. This is the no assistant technique started by Dr. Narang. Transferring haptic from one hand to the other, bringing the haptic out. Once both haptics are out, look, there's a lot of haptic externalized. All I do is trim it because it's a microcornea eye. Then tuck the haptics inside the tunnel, 26 gauge Chariot's pocket there inside. Once that's done, now remember, I'm going to break the adhesions to the periphery. Once those adhesions are broken, I can go into the phacoemulsification and emulsify all these sombering rings. So this is the way to manage patients with microcornea, aphakia, and sombering ring. In other words, I've shown you how to use a glued IOL as a scaffold to manage not only the microcornea, but also to manage the sombering rings. Once all the sombering rings are removed, take out the iris hooks. And once those iris hooks are okay, these patients normally will have nystagmus. They can improve to even 636, which is excellent vision for these people. And you'll see the immediate post-op of this patient. Post-op day 2 itself, vision is 636, and you can see the nystagmus present. Now, this is the first case which I thought I'll show you. Now, let's take another case and make it more difficult, okay? Look at this patient here now. This patient has got aphakia, no doubt, but there's a huge scar. I want all of you to see this picture there. When you do a pentacam, there are so many images, it will become very confusing for everyone. Take the one where there are 6 images. That is the important holiday pentacam report. Now take the one in the middle. Look on the top there. It shows astigmatism about 3.764. And the RMS HOA, you see it is in red. It's showing about 6. So if I just magnify that game a bit, I'll just show it to you in a second. This is what it was showing as. Remember, like you have myopia, like you have hyperopia, in 2002, we published the terminology as aberropia. Normal aberration should be 0.3. In this case, you can see it's 6.3. Till 1 year, okay. If the patient has got 1 to 5 aberropia, make your pupil 1.5. If it is 5 and above, go for a 1 millimeter pinhole pupil. So that's the basic concept which I thought I'll show you all. Now, let's come back to the patient here. This patient has a large white to white. You can see it's 12 millimeters. Now, when the patient has a large white to white, I'm making my scleral flaps. Once my scleral flaps are made, look at this. How do I externalize the haptics through a large white to white eye? I've got fluid in the eye. Previous case, I showed you trocar ACM. Here, I'm showing you through the pars plana. The simple trick is to do a peripheral iridectomy. Look at this. I'm making a small iridectomy in the periphery. The advantage here is, once I've got that, I am going more anteriorly. I'll be about 0.5 to 1 millimeter from the limbus. People will tell you, go 2 millimeters from the limbus. If you go so far back, the amount of haptic externalization will be very less. So the amount of tuck will be less. Subsequently, you might get a subluxed IOL postoperatively. Look at this. Catch the haptic. Now inject. Do not worry. This lens cannot go anywhere. You're holding one haptic. The second haptic is outside the eye. Pull it out. Once that's out, remember that. Now do the handshake technique, the no assistant technique which I talked about. Transfer haptic from one hand to the other and pull out. Now you got both haptics out. Look at the amount of haptic externalized. It's a lot. And remember, this was a large eye of 12 millimeters, and these lenses are 13 millimeters only. Now you take a tunnel, create with a 26 gauge chariot tunnel as we call it, with a 26 gauge needle, tuck inside. Case not over, because this patient otherwise will go for a penetrating keratoplasty, which we want to avoid. Simple technique is, all of you, if you can, learn the single pass 4th row pupiloplasty. Once you have done that, I'm starting the 4th row pupiloplasty on one side. You can keep on repeating as much as you want. What is my game plan? My game plan is, I need that pupil to miss the central scar. 1, location where I want. 2nd, size about 1 to 1.5, exactly where I want. Invariably, when you go back and start your first pinhole, you'll make a 2, 2.5, and then the patient will go to 660 or 624, and you'll curse me. So I'm telling you now, sir, please, in the beginning itself, make the pupil 1 to 1.5, not more than that. If you make a mistake, ladies and gentlemen, make smaller. No problem. You can always enlarge with a YAG laser. But if you make big, you have to reoperate that patient and take him back to the OR. Now look at the large peripheral iridectomy it has become because of the pull on the 4th row pupiloplasty. That also can be closed by the 4th row pupiloplasty. As you can see, the pupil becoming smaller and smaller. Now my question is, do I close that iridectomy there? So again, using the 4th row pupiloplasty, I'll be closing that easily. And once that is closed, now see how the pupil is. At the end, you need a vitrectomy probe. So you can see now, before I close up everything, I'm seeing the haptic tuck is good. Now take a vitrectomy probe and locate it exactly, check the size. All phaco machines have got very good vitrectomy probes. You can use it. If you're good in posterior segment, like what I'm using here, I can use a posterior segment. But by and large, the principle is you're getting a pupil slightly decentered. Remember that. But that does not matter. It's slightly decentered only. Take out the trocar, fix the glue, close the case up. Now the question comes, how did this patient behave? Remember, the patient had come to you for a penetrating keratoplasty, but you are avoiding it. So you can see the pre-op picture, post-op within 1 week, the patient is already 612. Another beauty of these patients is they see distance and near without glasses. So it gets like a multifocal IOL. They get extended depth of focus. So I thought I'll just show you a couple of cases to show you on these IOL fixation techniques. I'm trying to show you more difficult cases to help you improve yourself. I'd like to thank Sujata and Mohan Rajan for inviting me for this conference and for this course of theirs. Thank you very much. If anyone has doubts, please ask me.
Amar, if you have any more interesting videos you can show, we have another 5 minutes.
Oh, yes, please.
If you have any questions, we are open. But
Sir, amazing videos, and I think in one video you have 5 innovations going. This thing is, where do you put the AC trocar maintenance? Sir? Is it better to put it at the limbus or in the cornea?
In the limbus or the limbus?
The limbus.
Because see, when you pull out, don't go through cornea, it indents the cornea. Please understand me, it will indent the cornea. So what happens if you go about ½ millimeter from the limbus through scleral area, it does not indent the cornea. You can do what you're saying, but the problem is there'll be slight indentation, you check it.
And can it be direct, or do we have to
I used to do
directly?
I used to do tunnel, now I do direct between you and me, easier. So since Sujata asked me to talk more, I'll just talk on another nice topic. She's given me another 5 minutes. So thank you very much, Sujata. So I thought I'll show you, this is an interesting case which I think we should see. Okay, now look at this patient. I've got a subluxed IOL. Please understand, these are progressive conditions sometimes. Okay? If you put these endocapsular rings, Cioni, Vioni, whatever you want to put, you can put. 10 years down, you'll see it lying on the retina. So here you see I made my flaps. Now you can see I'm making my iridectomy there. Once I made my iridectomy, I'm able to come more anterior. Look, I've come anterior. But the reason why I'm showing you this case is slightly more different. Like I showed you in a Sommering ring, the question is, can I do a glued IOL scaffold? So here you can see, I've done a bit of vitrectomy. Now watch, I'm going to implant the glued IOL behind the existing cataract. So you can see I'm catching the haptic now, slowly injecting. Once first haptic is caught, I will pull it out. Once that is out, okay, now next step is, I will see that is coming out slowly. Look, that lens will not go anywhere. Once one haptic is out, now you are safe. One haptic is out, other haptic is still inside the eye. Now look at this small trick. Take a small IV set, cut it. Pass it through a 26 gauge needle and pass that needle into the haptic. Now shift the IV plug into the haptic. You see that? Now what happens, a very simple technique. Now that haptic will not go down. This is called the George Byko Roger Steinhardt Safran plug. Now I'm going to do the handshake technique, and I'm doing it behind the cataract. So you can do it comfortably. You can see I'm passing my forceps from one hand to the other. Once that is done, you will see subsequently there, I will now externalize the second haptic. Once both haptics are out, again I'll put a plug on the other side also. So you can see now on both sides you will have the Byko Steinhardt plugs present. Look at the amount of haptic externalized. Again, look, it's a lot. Okay? Once that is done, both plugs are on. Now my case is simple. I have got my own posterior capsule. That is the IOL, which is a scaffold. Now all I need to do is take my phaco probe and emulsify this nucleus. In this case, it will be like a rat eating a piece of cheese. So I'm just going on nibbling till the whole cataract will come out. The cataract will not go down because my IOL is there, giving it full stability, giving it full support. Once that is done, you can see the final portions of the cataract being removed. Here you can see I'm emulsifying that cataract. And look, it's a dense cataract, okay? But I'm able to go down deeper because I'm touching the capsule where the IOL is. For me, the capsule now is the IOL. So that final pieces are done. All I need to do is take my vitrectomy probe and knock off this cortex which you are seeing present there. So I'll take my vitrectomy probe, knock it all off there, and you can see now the case nearly completed. Once that's done, all I need to do is take out those plugs which I had fixed inside that eye and tuck the haptics inside. So ladies and gentlemen, what have I done in this case? I have a subluxed cataract. I'm trying to show you how you can do a glued IOL scaffold and fix this case up. Now look, pupil is dilated, okay? At this stage, do the photopupillasty. Don't leave the patient just like that. Patient will be okay, but they will not be extremely happy. Whereas when I do this and make the pupil a bit smaller, you will see the patient extremely happy. There will be no glare. The vision is going to be excellent. Look at the Perkin's image, bang on track there in the center of the pupil. I'm using my vitrectomy probe to check everything down. Now let's see how this patient behaved at the end of the day. So this is a very simple case of glued IOL scaffold being done for sublux cataracts. Now apply the glue, seal everything down. Once everything is down, let's see how the patient behaved at the end of the day. And you'll see that here, this is how the patient looks. Look at the patient post-op day 1, 6-9. So pre-op was sublux cataract. Intraoperative, I showed you the glued IOL as a scaffold. You can see the plugs also of Roger Steinhardt, great man, and George Baiko, Steve Safran. Post-op day 1, 6-9. Glued IOL scaffold, phaco with the photopupillasty. Sublux cataract managed by glued IOL scaffold. Thank you very much, ladies and gentlemen.
Thank you, Amar. That was really, what you call spellbinding. And I request all of you not to follow Amar, because I don't think anybody else can do this. It's quite dangerous, but you can see how elegantly he finished the surgery. Any questions?
My question is to Dr. Amar Agrawal. Dr. Amar Agrawal, did you try pupilloplasty fourth row in a traumatic case, mydriasis with clear lens?
Okay, so the question is, can I do, simple question, what he's asking me is, can I do photopupillasty in a phakic eye? That's it, don't do it. If I have a case like that, I'll make him pseudophakic. You can try Yogesh Bhai, but the problem in these cases is, you'll hit the lens sometimes. So another method is, what Mahipal Sachdev has done is, he has put a ICL or a foldable lens inside the eye, then done the fourth row, before closing he pulls it out. So that's been published in the IGO also. But if you ask me, I'll make them pseudophakic.
Thank you.
Wonderful video, Amar.
Thanks,
I
Yogesh Bhai.
just have a small question. Is it worth doing pars plana vitrectomy at the end, in the last case which you showed?
Yeah, you should do a little bit, 100%. If you need it, 100% you should do.
Because
if you see vitreous anywhere, see, in my video it will be edited, but if it, I would always clear up everything. See that there's no vitreous inside, 100%.
Thank you.
Kamar, usually they say in all these cases, it's better to do a base excision and do a total vitrectomy.
I don't do it, unless it's a drop nucleus or something like that. This is just simple aphakia. So in this, I'll do a little bit. See, the idea of this is what? Simple. When I'm putting the IOL inside, I don't want it to go into vitreous. So if I don't have vitreous, I've got fluid. If I've done an anterior and mid vitrectomy, it's enough. In this type of case, I'm not talking of dropped IOLs and dropped nucleus. That's a different ballgame. But if I just have it this much, my idea is when the IOL goes inside, I don't want it to hit into the vitreous. So if I've done an anterior mid vitrectomy, as an anterior segment surgeon, all of you can do that very comfortably. You don't need to refer a glued IOL to a retina guy.
So where is this ACM trocar available?
Very simple. You go to, I had designed them from Mastel, but now very simple. That person passed away recently. So you go to Alcon, or if you have a good friend in retina, you'll be having 100. Ask them to give you the Alcon Trocars 25 gauge blue color ka bahut acha hota hai. The orange color which I've shown you is 23 gauge. You can use that, but it's a bit large.
25.
My suggestion is go for the 25
And
gauge
you go
blue color
beyond the
ones.
limbus, just beyond the limbus and parallel.
Just half millimeter from the limbus. See, when you
Parallel
go
to the
past
limbus,
planar,
sir?
you're scared. You do not know. Sometimes you don't see. Here, you're just half millimeter from the limbus.
Yeah,
You're
I
above the
agree.
iris.
We are scared to do that one. So do you go parallel to the cornea or the
Parallel.
iris plane?
Exactly parallel. Nothing will happen.
25 gauge.
Yeah.
Thank you so
You
much.
can make a tunnel. I used to do that, but I can make it simple. If it is blunt, Kirti, 1 minute, listen to me. You see, sometimes, I tell you, all of you, sometimes, look, I'll be very honest, I repeat the trocars. We don't just throw them off. So after the second or third time they get blunt, take a side port knife, make a small incision, and
MBR
then enter.
and MBR.
Sorry, they're calling me. Bye-bye.
Thanks everyone for staying back and listening to this wonderful course. And